And this is just a very quick look at our agenda. So we're here in the welcome. We're going to have a panel all in this room together talking about harm reduction history. We'll have a break. We have a panel talking about federally qualified health centers and syringe services. That's also in this room. Then we are going to break for lunch. When we come back, we'll be going into the 3 breakout sessions. We did send out an email just kind of feeling out where folks wanted to go. And so these are our 3 topics. We have Latinx communities, frontline service delivery, and reproductive health for people who use drugs. This is the rooms that they're going to be in. We'll post this again, so when you come back from lunch, this will be up. You can see where you're supposed to go. This is Harbor C that we're in right now. Harbor B is just out and to the left, and Harbor A is you kind of go a little further around as if you're going to the bathrooms, and it's right through this wall. We'll have another break, and then our final panel of the day will be kind of looking back to move forward, thinking about frontiers in harm reduction. So this is our day. We're so excited. And with that, I'm going to pass it over to Bobby Watts, our CEO, who's going to officially welcome us all.
Good morning. Just so really thrilled to be here. And I don't deserve any applause, but for the planning committee, their names were raised. We really should be giving them a round of applause. So let's do that. Thank you. I've been a long-time member of the council when I was working in a healthcare for the homeless agency in New York City for many years, and would always love coming to the conference. But now that I'm on the other side, working for the council, I see how much work goes into the conference and each planning work group for the pre-conference institutes and the learning labs and for everything. And it is a monumental labor that takes the whole staff. And so I just really wanted to make sure we gave them applause and thank you for that, because we are the beneficiaries of learning from each other, but it takes setting the stage, setting the vessel, and the magic of the council is that we learn from each other. So we have a wonderful agenda. I'm really looking forward to it, and so it's just really my honor and privilege to welcome you. And I was asked to say a few remarks. And over the years, and I've been working as a public health professional focusing on healthcare for people experiencing homelessness and other similar populations for my whole career. I've been very extremely fortunate. And over the years, I wish I had known what we know now about harm reduction 30 years ago. About 35 years ago, I was living as a live-in counselor at a rescue mission in New York City, did that for 2 years, and saw firsthand the struggles that people had. And at that time, the mindset was abstinence was the goal and the only goal. And I just think that is so unlike what we say about everything else in life. If someone wants to cut down cigarettes, stop cigarettes, if they can reduce from 2 packs to 1 pack to half a pack, we think that is good and we applaud them. But when it comes to other substances, we have a one-way approach, which is 0 or none. And that is just unfair. I see this from working as a public health professional for a long time. And as we think about our family members, I think about my family members that have struggled with pain management and substance use. We should be really grateful when they can make steps towards protecting their health, even if they can't stop using substances completely. So this is so important that we are gathered here today and that this room is almost full. Last year, one of our keynote speakers at our conference was Cassandra Frederick, the leader of the Drug Policy Alliance. And she really brought home to us that our movements to provide health care for people experiencing homelessness, the movement to change policy around drug and substance use in this country are really aligned, and that we need to work together. And if we don't, we really won't accomplish what we need for those that we are trying to serve, or to create the type of society that we know we want and the type of society that we know we need, where we are meeting people's needs where they are, not where we say that they should be. So I'm really glad that we can follow up immediately at this year's conference by working together with the National Harm Reduction Coalition. We are so grateful for this partnership. And The importance of working together was underscored about 3 weeks ago. I was with Kate, who welcomed us in Philadelphia, visiting Project Home, which is also on the agenda, looking at their clinic in the hub in a main transportation center in Philadelphia. And then also looking at another organization, Prevention Point in Kensington. Now, I grew up in inner city Brooklyn, spent a lot of time working and worshiping in Harlem, and this is in the 80s and 90s, where I saw the ravages of the crack epidemic and heroin firsthand. But Kensington has the reputation of being the biggest drug area in the country. And when I was walking through the streets and looking, I had to say, yes, it is. But visiting Prevention Point, a few of their services, but one in particular, their syringe exchange, where they say they exchange 10 million, they give out 10 million clean needles a year, and they receive 8 million back. That's a really high rate. And I think of all the lives that are saved, and the need for us to work together, not just on melding our services, though that is extremely important, but also for addressing policy, was underscored. The very next week, the Pennsylvania state legislature passed a bill that made it impossible, that outlawed any city, even if the city wanted to, establish a safe drug consumption site. They said that no city in the state of Pennsylvania can do that. So it's clear that we are operating under a double standard. It's clear that we have to unite to save the lives of our patients, of our clients, and to effect changes in drug policy, public policy, if we're going to make the difference and build the society that we need. So I am just really grateful for what you're doing, for how you are advancing public health, how you are advancing human health, how you are advancing human rights. And speaking for the National Healthcare for the Homeless Council, thrilled that we can partner with the National Harm Reduction Coalition in this important work today. And I look forward to learning with all of you how we can go even further, how we can improve our services, how we can work together to build a better and more humane and just society as we work towards justice for all. So thank you for this great opportunity, and I look forward to working and learning with you today. Thank you.
Thank you, Bobby, so much. So I'm going to just turn it over to our colleagues from National Harm Reduction Coalition to do our land and labor acknowledgement and to lead us through a grounding exercise to start the day. So I'll pass it right over to them.
Good morning, everybody. I want a show of hands. Who's from Baltimore? Oh, a few people. Who remembers the Paradox nightclub? Ah! Okay, I am Emma Roberts. I'm the Senior Director of National Harm Reduction Coalition. I am so glad to be back in Baltimore. It's been many years since we've been able to be together here, and I have a particular fond memory of coming to the Paradox nightclub and dancing there before it closed. It had the best sound system ever. Even the rubbish records sound good on that sound system. So that is one of my wonderful memories. We also, in 2014, the National Harm Reduction Coalition had our national conference here. So again, a lot of fondness for this city and the folks that we work with on the ground there. So it's so good to be back. I'm here with my colleague Tanagra, who will introduce herself in a moment, and she's going to lead us, first of all, in Spanish. We're going to read the land acknowledgement, and I will follow up in English.
Buenos días. Good morning. As Emma said, my name is Tanagra Melgarejo Pulido. I'm excited to be here. It's my first conference of the National Healthcare for the Homeless Council, so I'm thrilled to be in Baltimore as well. And I will start by reading the land acknowledgement in Spanish. I'm going to use one of those microphones if I don't have. I'm gonna be doing it here because I don't want to disrupt that. Basado en una declaración de reconocimiento de tierras redactadas por un anciano de Susquehanna y Shawnee, ancianos chopóticos y consultores tribales de la nación india Piscataway para el proyecto de reconocimiento de tierras del Consejo de las Artes del Estado de Maryland. Reconocemos que el lugar que hoy se conoce como Maryland existe como resultado de la coacción. En 1652, los líderes de Susquehannock fueron forzados a transferir estas tierras a los ingleses en un esfuerzo fallido por detener a los colonos ingleses que invadían el río Susquehanna. Reconocemos que estos lugares y sus habitantes indígenas existían y existen sin fronteras políticas rígidas y límites mantenidos por colonos y gobiernos de colonos. Reconocemos las relaciones sociales, físicas, espirituales y de parentesco que esta tierra continúa compartiendo con las naciones indígenas del río Susquehanna y la bahía de Chesapeake. Reconocemos que estas relaciones han sido desplazadas, dañadas y disipadas por la insaciable sed de adquisición y dominación de los colonos. Reconocemos un lugar desequilibrado con su verdadero propósito en el ser. Reconocemos nuestra ocupación de las tierras de Susquehannock. Reconocemos la presencia continua de las naciones indígenas y el refugio y alimento que este lugar continúa brindando a todos los pueblos indígenas que viven aquí hoy. Reconocemos nuestra responsabilidad con las naciones indígenas para reparar las relaciones enfermizas y administrarlas toda la vida. Reconocemos que la nación indígena Piscataway continúa manteniendo una relación con las tierras donde nos reunimos hoy. Junto con la tribu Piscataway Conoy, la nación india Piscataway recibió el reconocimiento del estado de Maryland en el año 2012. Reconocemos su parentesco de larga data con estas tierras y aguas y reconocemos que somos visitantes, no invitados en tierras indígenas. Para que esta declaración sea más significativa, los invitamos a aprender más sobre la nación india Piscataway y sobre las declaraciones de reconocimiento de tierras a través de los recursos disponibles en el msac.organización y otros lugares, para considerar la posibilidad de donar o poder poner recursos institucionales a la disposición de pueblos tribales y para reconsiderar en qué maneras podemos mejorar nuestra relación con las tierras que administran. También nos gustaría reconocer a las personas libres secuestradas en África que fueron esclavizadas en estas tierras. Desde la fundación de la colonia en 1634 hasta 1864, cuando el estado de Maryland abolió la esclavitud, los esclavos africanos y afroamericanos fueron importantes en la configuración de la historia del estado.
Gracias. Tanagra. So this land acknowledgement is based on a statement drafted by Susquehanna and Shawnee Elder, Chiptico elders, and Piscataway Indian Nation tribal consultants for the Maryland State Arts Council. We acknowledge that the place today known as Maryland exists as the result of duress. In 1652, Susquehannock leaders unwillingly transferred their lands to the English in an unsuccessful effort to stop English settlers encroaching up the Susquehanna River. We acknowledge that these places and their indigenous inhabitants exist without rigid political borders and boundaries maintained by settlers and settler governments. We acknowledge the social, physical, spiritual, and kinship relationships this land continues to share with indigenous nations of the Susquehanna River and Chesapeake Bay. We acknowledge that these relationships have been displaced, damaged, and dispelled by colonists' insatiable thirst for acquisition and domination. We acknowledge a place out of balance with its true purpose in being. We acknowledge our occupation of the Susquehannock lands. We acknowledge the continuing presence of indigenous nations and the shelter and nourishment that this place continues to provide all native peoples who live here today. We acknowledge our responsibility to indigenous nations to repair unhealthy relationships and to steward all life. We acknowledge that the Piscataway Indian Nation continues to maintain a relationship with the lands where we gather today, along with the Piscataway Konyo tribe. The Piscataway Indian Nation received recognition by the state of Maryland in 2012. We acknowledge their long-standing kinship with these lands and waters and acknowledge that we are uninvited visitors on indigenous lands. To make this statement more meaningful, we invite you to learn more about the Piscataway Indian Nation and about the land acknowledgement statements via resources available. We would also like to acknowledge the free people forcibly kidnapped from Africa who were enslaved on these lands. from the colony's founding in 1634 until 1864, when the state of Maryland abolished slavery, enslaved Africans and African Americans were important in shaping the state's history. Okay, so I'm just going to stand for this bit. Okay. All right. So I just want to then also lead us in a grounding. And if you feel able to, you can close your eyes or you can just lower your gaze. But I'm going to share a reading with you from a good friend of ours. Some of you may know Adrienne Murray Brown, who was also a member of National Harm Reduction Coalition. She's now an amazing facilitator, author, and activist. And this is a spell to cast upon meeting a stranger, comrade, or friend working for justice and liberation. You are a miracle walking.
Eres un milagro que camina.
I greet you with wonder in a world which seeks to own your joy and your imagination. You have chosen to be free every day as a practice.
Te saludo maravillada. En un mundo que busca poseer tu imaginación y tu alegría, has escogido ser libre, cada día como una práctica.
I can never know the struggles you went through to get here, but I know you have swum upstream and at times it has been lonely.
Una nunca sabe las luchas que has enfrentado para llegar hasta aquí, pero sé que has nadado en contra de la corriente y te has sentido desolada.
I want you to know I honor the choices you made in solitude.
Quiero que sepas que honro las decisiones que tomaste en tu soledad
And I honor the work you have done to belong.
y que honro el trabajo que has hecho para pertenecer
I honor your commitment to that which is larger than yourself
y honro tu compromiso con aquello que es más grande que tú
and your journey to love the particular container of life that is you.
y que tu travesía para amar en ese recipiente de vida excepcional que eres tú.
You are enough.
Eres suficiente.
Your work is enough.
Tu trabajo es suficiente.
You are needed.
Te necesitamos.
Your work is sacred.
Tu trabajo es sagrado.
You are here and I am grateful.
Estás aquí y estoy agradecida.
Thank you, everybody. So we're going to move into our first session, but before we begin that, I just want to acknowledge that we also have our colleagues with us from Puerto Rico. We have a group of program leaders and staff with us to help us through the day. And so we wanted to lead with language justice, which is also why we are incorporating as much Spanish language as possible in the room. So I'm so grateful for them for making the trip all the way to Baltimore to be with us. Thank you. So Tanagra and I are going to lead you through some foundation slides that we use at National Harm Reduction to talk about the foundations, the history, and also around stigma and language. Some of you in this room are probably are more seasoned harm reductionists, right? Some of you are new to this. So we love the fresh eyes of those of you that are new to this. Those of you that are more seasoned, this is an opportunity for you to see how we talk about this topic and these issues. And you will receive these slides. You are welcome to steal any of our material. Just acknowledge us.
Reclaim.
Yes, reclaim, that's it. Okay, sorry. Reclaim it. Because that's what we create this material to be public for people to use. We just ask that people acknowledge us if they use it. So I'm going to hand it over to Tanagra.
Thank you. So I am so excited. I love thinking about history and also grounding us in history. I think history and her story. Why does it have to be gender, right? La historia, ¿verdad? Lo que pasó, what happened, before us, the people that walked before us that made it possible for us to be here today. If we think about this work 30 years ago, people were doing this because it had to be done, because lives were being lost, and because we deserve better, right? So people organized, we didn't ask permission, we just did it. And we did it against odds because it's illegal. It was illegal. It's still illegal in some countries to do this work, harm reduction work, right? It makes sense. It's common sense work and still illegal. So for me, it's really important that we don't forget where harm reduction came from, right? And for those of us that are newer to this movement, I would hope that you take this idea of who came before us, because they were there before us for us to be here today. So when we think of harm reduction, right, we most likely have heard about harm reduction services, right, and harm reduction with little h, little r, right? Harm reduction services are the things that we do, the practices, right? Naloxone distribution, right? Syringe service programs, offering smoking kits or snorting kits to folks, condoms, right? Offering wound care, offering housing to folks. To me, housing is a human right, and it's also part of the harm reduction continuum. Making sure folks are well-nourished, right? That folks feel good within themselves, mental health, physical health, all of those things are harm reduction services. And then we have the little h, the little r, right? Which is the application of this framework broadly in other movements or networks, right? Thinking about helmets, thinking about seatbelts, right? But we normally don't hear about harm reduction as a political movement, right? We don't hear about harm reduction as a philosophical and political movement that was started by people who used drugs during a pandemic in the 1980s, the HIV/AIDS pandemic, because they were being left out of conversations that were happening, policy conversations as to how to address that pandemic that was also impacting them and their communities. And we organized, right, because we had to, and we demanded a space at the table, and we built our own table also if we didn't get room in that table, to demand access, to demand policy that made sense and that included us, right? So we cannot forget that harm reduction is rooted in challenging injustices, challenging violence, challenging white supremacy culture, and challenging capitalism. So we have the harm reduction approach, right? This is what we mostly have heard, right? It's a spectrum of strategies that we can use. I love harm reduction for many things, but one of the things that I love the most is that it gives us so many opportunities to connect with people and so many tools, right? It's a smorgasbord, a buffet. I love to eat, so I always think in analogies of food. You know, it's a buffet of options that we can provide people, or we can think through with people, and also we can learn from folks too. Many of the strategies that I can offer folks today are strategies that were shared with me by program participants, right? That they gave me that gift. So harm reduction gives us that opportunity, and we can do that through safer techniques. And that means, for example, enabling folks to have access to service to sterile equipment, new sterile equipment, right? When they're using injection substances, or when they're thinking about smoking or snorting, right? Giving folks access to condoms if they want them or need them, having access to naloxone, fully available to them. So those are safer techniques. Then we have managed use, which is that space that we can engage people in conversation when they're thinking about reconfiguring their relationship to a substance, but they're not wanting to, or we don't expect them to change or move into abstinence, right? This is when I'm thinking about, okay, what I've been doing, I want to rethink. I may want to use less. I may want to use through, instead of injecting, I want to snort, or maybe I want to try smoking, right? I'm trying to think about when in the day I use, right? And in what context. That's managed use. And then finally, abstinence. You know, there's this myth out there that we want to bust, that harm reduction doesn't believe in abstinence. We believe in abstinence if that's what the person wants, if that's what the person is choosing. The road to abstinence, the road to change in general, I will speak for myself. It's not easy, right? I may want something, it doesn't make it any easier. And so we know that there are a lot of barriers for people in general in this world, particularly people who use drugs, and getting to abstinence is not easy. So the person has to desire it and want it, and we need to listen to what their definition of abstinence is, right? My definition of abstinence may be different to someone else's in the room, and that is okay. Because harm reduction is about working with the human being, with the person, and we're all different, right? So we need to listen to what that definition of the person is. And then harm reduction is a movement, as I said, it's a movement that believes that public health equals social justice. It is a movement that believes that we need to end inequality and oppression, and that the only way that we're going to do that is by fostering the health and liberation of everyone, including people who use drugs, first and foremost people who use drugs. That the real causes of harm are not drugs themselves, but racism, stigma, criminalization, white supremacy culture, capitalism, trans and homophobia, gentrification. That's the real causes of harm. That's what causes violence to people and causes death. And finally, that the only way that we will achieve transformative change is by centering, trusting, and believing in the leadership of those that are most impacted. And in this case, in this room, are people who use drugs, people who experience housing insecurity, right? Black, brown, indigenous people. I also want to name that when we're thinking of the history of harm reduction, we also have to think about personal autonomy, right? That's a really important concept that has been embedded in the philosophy of harm reduction since its inception, and we're going to look at that in a minute, right? In this capitalist system, when you're poor, when you use drugs, when you're female identified, when you're queer, you're not expected to have personal autonomy. People tell you what to do. You abdicate your right to privacy when you enter services. And if you don't disclose fully who you are, then you're told what? That you're told that you're a liar, that you're holding back information. Because the expectation is, because I'm poor, because I'm brown, because I'm female, because I'm queer, because I use drugs, somehow I have to disclose all those things, right? I have personal autonomy. I get to make the choices. I get to build trust with someone to then see how I feel about disclosing certain things about myself that are not necessarily pertinent for me to access those services. We have to remember that. We have to remember to center personal autonomy and people's choice to engage in that, right? I think that is essential for us as providers, as people in this movement. Those of us that have had our personal autonomy attacked know that that doesn't feel really good. And when you encounter spaces where you're actually enabled to be who you are and you get to experience trust and decision-making power, it shifts completely, at least for me, has shifted completely my experience in the process. And also, harm reduction asks us to practice radical neutrality and acceptance. And I'm going to read this from, it's an excerpt from one of Jeannie Little and Pat Denning's books. If you have not met them, I will encourage you to look them up. They run the Center for Harm Reduction Therapy out of San Francisco, California. They've been long-time harm reductionists. And they have gifted us this idea of radical neutrality and acceptance. Practicing radical neutrality implies grappling with ethical gray areas, tolerating, accepting, and understanding difficult behaviors, being open and humble enough to be taught by our clients, relinquishing the role of authority, judge, or expert, because what we want to do is we want to partner with our clients, right? That's the essence of harm reduction. That's the essence of trying to shift and change, as Bobby was saying, the systems and structures that lead us to do the opposite, right? That lead us to dehumanize, to stigmatize, to shame people. And so before there was harm reduction, we had harm reduction. How many people here have heard about the Young Lords? Yes. Black Panthers. Yes. Folks that fought for people that belong to the LGBTQI communities to have freedom and rights, Stonewall, right? Yes, so before that, we had bus boycotts in the South, right? We had people challenging and questioning systems of oppression, right? And so those were the original harm reductionists, right? That's harm reduction. The original harm reductionists are everyday folks, like us here in this room, that fight for access to free and quality health care for everyone, for nutrition, for treatment for folks, for substance use treatment, mental health treatment, child and elder preventative care programs, for universal education, for housing, for a living wage, for work safety. Because what's good for those that are most marginalized is good for all of us. And ultimately, harm reduction to me, and Rafi Torroya said this, is about loving people back to health. It's about love. It's radical love. right? And I just want to name that Dr. King said a long time ago, and it's sad that today this still stands true, that of all the forms of inequality, injustice in health is the most shocking and inhumane. We live in a country with so many riches and resources, and it's unbelievable to me that we still have people that don't have access to the healthcare they deserve because it's a human right. So harm reduction started in Europe. It started in Liverpool, England, by a group of folks that organized under the Merseyside Collective, people who use drugs that were being impacted by HIV, by Hep C, and decided to come together and do what they needed to do to keep their people healthy and safe. And so they started the first needle exchange. And this person here that you see, who knows who this person is? Well, you'll know now. Su nombre era Edith Springer. I invite you to say her name after me. Edith Springer. Edith Springer was a social worker, a person who used drugs, a person who loved people who use drugs, one of the founders of the National Harm Reduction Coalition. And she went to visit Europe, and she went to Liverpool. And she met with the folks at Merseyside. And she thought, we need to be doing this back home. And she asked for permission and brought back the principles of the Merseyside Harm Reduction Collective to the United States. And these principles were: HIV is a greater threat than drug use. Abstinence should not be the only goal, or necessarily the first goal, or a goal at all. We need to reach out to users, as it is a language that they used in the 80s, to people who use drugs, and engage them. We need to connect and learn from folks that use drugs. We need to provide, and I don't know how you pronounce this in English. I want to say both ways. Innovative or innovative? Which way is it? Innovative? Gracias. You know, I like to make up words sometimes, so. And we need to use a multidisciplinary approach, again, to what Bobby was saying earlier. We need to end what Cassandra says. We need to work together. Our movements make sense together. So we need to, and also we're whole human beings, right? I'm not only my arms or my heart or my brain, right? I'm a full person, so we need to use that multidisciplinary approach to be able to connect and support people. And so Edith brought this back to the United States, and I want you to also see this person here. We'll say his name, Dave Purchase. Dave Purchase, one of our forefathers, a person who's no longer with us, but his steps brought us here. Started the first ever harm reduction program in this country, and you're looking at it right there. That table there is the first harm reduction program. Huh? Yeah. Yeah. And so it was open in Seattle, and when people came to the table, right, what they asked him was like, what are we doing? He said, you give me a used one, I give you a new one, and this saves your butt. It's very simple, right? And they didn't ask for permission, just set up the table and started this. And so harm reduction from the 80s started taking root in the United States. We started seeing into the 90s, you know, the National Harm Reduction Coalition was founded in 1994 in Oakland. Oh my God, we're gonna be how old in 2024? 30 years. 30 years. But before that, we had the first National Syringe Exchange Conference in Boston, and the working group, the Harm Reduction Working Group, was formed in 1993, and that included Dave, and that included Edith, that included Dan Big, that included Ricky Blumenthal, Imani Woods, it included Joyce Rivera, Lisa Moore, many other people. I'm forgetting. There are so many of them. Heather Etney, we'll see a picture in a minute, I think, of the working group. And so they started, Mary Comer Foundation was there too. One of the founders of the Comer Foundation was there. And so they started thinking about what this could look like as a movement here in the United States. Because, you know, as a movement, we're stronger when we work together. And so here is the working group. And you can see Stephanie Comer, John Paul Hammond, and then we see folks like Delia Garcia and Gerald Lenoir, all of those folks. Some of them are no longer with us, we have lost them. I just want to name that if you know naloxone, or what we name as Narcan, right? And we see it today in the hands of people who use drugs, it's because of damn big. EMTs, for a long, long time, in the 80s, in the 70s, had naloxone available to them. And they were informally giving it without permission, because why do we need to ask for permission when something is right? They were giving it to people who use drugs, informally, right? And so then, in Oakland, we have some, ¿cómo se dice eso en inglés? Ay Dios, como... We have heard from folks, and we have the horror history that has been written down by folks about this happening, EMTs handing out naloxone to people who use drugs because they knew it would help reverse an overdose. But then Dan found this out because he was connected to the community of people who use drugs and ran a program, and he said, okay, so how do we get this? And he connected with a tiny pharmaceutical company, and he said to them, I just want to get naloxone. And he started purchasing it. And he would buy it, and the pharmaceutical would produce it for Dan, and he would bring it in these big duffel bags, right? And he would start handing it out to people, right? This is before anybody who used drugs, could have access to naloxone, because he believed that the first responders are people who use drugs, their communities and their families. And so Dan used his white, male, cisgender privilege to engage in an activity that was illegal, because he was protected by those privileges, and he wanted to make sure that people who use drugs today could have access to that medication. And we're seeing now huge shifts and changes in the way that naloxone is available. We have over-the-counter naloxone that has its issues, but it's the first time ever that we are going to see it, right? And we still believe that we need to saturate the communities with naloxone. Community-based distribution of naloxone is the most important thing. So thank you, Dan. Again, personal autonomy, right? It's part of harm reduction, and it's part of what we believe. And these are the foundational elements of what harm reduction is. We want people to be involved, our participants to be involved. We want them to lead programs. We believe that any change is positive change as defined by the person. We want to work towards building supportive agency policies, and we want to build collaborations with other providers. That is really, really important. And so harm reduction took root in the United States throughout the 2000s. We start seeing Good Samaritan laws being passed. We start to see a decline in the HIV transmission rates amongst people who inject drugs. We start also to see a second wave of opioid-related overdoses to begin. And we lost more than 100,000 lives at this point. Into 2020 and 2021, we just saw a year ago, right? State of the Union address, first ever sitting president of this country, name or say the words out loud, harm reduction, right? We know harm reduction works. We've known it. We have the stats, we have the graphs, we have everything, right? We know it works. We see it in the practice. We hear people tell us. And also, it's nice to hear a president say out loud those words and commit their administration to supporting this life-saving work that we know works. And so we've come a long way to go. We've come a long way, but we have a long way to go. We have seen expansion in medication for opioid disorder. We have seen expansion in naloxone distribution and access to naloxone. We have seen expansion in harm reduction programs. The partial ban that was in place was lifted. Part of it was lifted. We still have a ban on using funds to purchase equipment that people who use drugs use to stay safe. So there's a ban on using federal funds to pay for syringes and other equipment that was meant to be lifted, but when they heard that there were crack pipes involved, racism, right? Just big kerfuffle, right? How can we give out crack pipes? And I'm like, because, people are going to smoke and people have been doing drugs since we've been people. And we want to do them safely and well, and why not, right? And so and so we're working, hopefully the federal government, they're working, our colleagues are working to hopefully see this reversed and have this ban lifted so that programs can use this funding and this money to actually purchase for those resources. We've seen decriminalization, we've seen advances in how we look at marijuana, we've seen the elimination of perinatal laws in some states and some scaled up Good Samaritan laws, and we still have a long way to go. We still need to continue to talk and center racial equity. Our movement needs to do that. Our movement needs to sit down and talk about, the impact of sexism and misogyny in our movement, right? We haven't done that. We need to continue to center and continue to listen to the voices of our sex working friends and collaborators and colleagues, and we need to engage in a process of reparations and accountability. We need to think about long-term sustainability, and I would say long-term sustainability without having government involvement. Because when we have government involvement, they need to be involved, but I don't want them calling the shots. They have a right, it's reparations, but I don't want you, because you give me money, to tell me what harm reduction should look like, because then what happens is then our movement loses sight of our historical background, which is we are a political movement. We're a movement for social change, right? We want to build more, we want to build recovery organizations into harm reduction. We want to work closely with folks, because if relapse is part of recovery, then we have to be ready. And we want to work to establish a national harm reduction strategy that can help us guide those conversations and tell the federal government how we want to use their money, and have them tell us, sorry if there's federal people in the room, I don't know, may get in trouble afterwards. And so as of 2023, we have almost 600 harm reduction programs. 30 years, almost 600 harm reduction programs in operation in the United States. It says it's territories, but there's also colonies. Puerto Rico is a colony of the United States. Let's not forget that, and counting. And we have 11 states that still don't have legal syringe service programs. If you go to the NASEN.org page, you can find a list of all these programs. If you want to know where these harm reduction programs in these 11 states are, or people in those states that are doing work and they don't have programs officially, but you want to support them, reach out to the Harm Reduction Coalition. Those folks would really appreciate solidarity. Harm reduction supplies are expensive, particularly when you're paying for them out of pocket. And these are folks that are doing this because they believe it's the right thing to do. So if you want to support folks in those 11 states, Emma and I are here, Jose is there, people in this room are here, talk to us, we can tell you more about it. So these are the services we offer, not the only services, but primary services. As you see, Housing First is there. We offer overdose prevention, safer sex materials. We connect people to medication for opioid use disorder. We do a lot of different things as part of harm reduction services. And when we think of harm reduction or practicing harm reduction, we have the principles of harm reduction and we have tools and services. And as Emma says, you can be offering all the tools and services in the world, but if you're offering them with a big bag, hulking bag of stigma, shame, and dehumanization of the side, you're not practicing harm reduction. You don't have to give out one cooker, one syringe, one condom, and you connect with your participants with love, with empathy, with care, with kindness. You see them for who they are, full human beings. You uplift their leadership and you're practicing harm reduction. So thank you. I don't know if we have time for the video, so there's a video here. You're gonna have access to the slides, and then I'm gonna let Emma move on to the next piece.
No, it's fine. You're good. I was watching the sound. Thank you, Tanagra. I am such a privilege to work with Tanagra every day in this field. As someone who was born 15 miles from Merseyside, this history is close to my heart. And also as someone who's been practicing for nearly 30 years, I feel really, really old. But I think I look cute still, right? I started harm reduction in the mid-90s in the north of England. In case you can guess, I'm not from America. I'm from the north of England, and I started doing harm reduction in the mid-90s in a community centre when heroin proliferated across the UK at that time and became much more available. I came back from 8 months maternity leave. Yes, we get 8 months of maternity leave in the UK, unlike 8 weeks. And I had my son in tow. My son was in the creche room, and we started a syringe exchange in the corner office of our community centre, because when I came back after 8 months, many of the families and young people that I've been working with were either impacted by their own drug use or someone in their family. So I've been doing this work a long time. And it's really important to us that, Tanagra shares the history with you, because what I'm finding is that people are coming to me and asking me about harm reduction and think it was invented last week, when it was not. We have been around a long time. I also just want to say that I then came to New York in 2008, and I got the privilege to come to the Healthcare for the Homeless conference when I ran a mobile medical, dental, and syringe service program in across New York City. So that's my background in the US. So I'm going to talk a little bit about stigma, because as Tanagra mentioned, right, for me, after 30 years, I can categorically tell you that one of the biggest killers of people who use drugs is stigma. More than it's more dangerous than the drug itself in many cases, right? Because stigma keeps people disconnected, it keeps them away, it keeps them underground, right? So this is why it is also very important for us to talk about stigma whenever we do these presentations. So one of the ways to think about how stigma comes about, let's do it that way, is, how do we start to stigmatize people, right? So we form stereotypes and ideas in our mind of what someone who uses drugs, in this case, right, who they are, what they do, what kind of traits they possess, right? And we form these stereotypes, right? So, for example, people who are blank are incapable, fragile, dangerous, they can never recover, they're in denial, right? They're irresponsible, they don't care about anybody else, they don't care about their kids, they don't care about their unborn child, right? All those different stereotypes around people who use drugs. And then what happens is that we take those stereotypes and we form our beliefs, right? That people who use drugs are scary, they're less than. And then we form, and then we act upon those stereotypes and those beliefs. So the action is the discrimination that then comes about either socially, right? I don't want to live next door to those people. I don't want my kid to marry someone who uses drugs, right? Those social things. And then also it becomes structural, right? When all those individuals that are holding those stereotypes and beliefs get together in a group, we see structural discrimination, right? People don't want to hire people who use drugs. Or if somebody's working somewhere and they use drugs, they immediately get fired without any support. We don't want to offer education grants to people who have felony charges for drug use, right? So it keeps people stuck, right? It keeps people pushed down. It doesn't allow them to fully recover in the way that they would want to recover. It affects people's access to housing and access to health insurance, right? And all the other services that they deserve as a human being. We also recognize that stigma intersects with harm reduction, right? We want to acknowledge and recognize that it exists. That's part of our principle of being practical and realistic. It exists. There are ways to manage and challenge stigma. Sometimes we can't remove it completely all at once, but we can take lots of little steps, right? We say any positive change within harm reduction, we can apply that to how we challenge stigma and discrimination. We also recognize that stigma changes over time. Right, if you think about HIV and AIDS today, right, versus how it was stigmatized in the 80s, there's still stigma around HIV today, but it looks very different, right? I used to use the concept of smoking, right? Smoking used to be cool when I was coming up, right, in the 70s and 80s. Now, not so cool, although in some respects it's getting cool again. So, but you can see, right, it changes, right? And that's really important when we think about language. I'm going to show you a slide about language in a moment, right? Because language becomes loaded. Right, we've changed our terminology over time, but even that language can become loaded. And that's why it's really important that we listen to people who use drugs to tell us about the way they want to describe themselves and the way they want to describe their relationship with substances. It's not about how we think it should be described, right? So even the word addict or the word addiction or the word a disease, for some people is stigmatizing, right? So when someone comes to me and says, okay, I believe that addiction is a disease and I'm not a bad person and I can get treatment, I'm like, I'll work with that. But when someone comes to me and goes, hell no, don't tell me I've got a disease, right? My substance use, a colleague said to me this once, my substance use is because I saw my brother murdered in front of me, and using substances was the only way that I could keep myself alive in that moment. So don't tell me I have a disease. And I'm like, okay, I'll work with that, right? It's not when clinicians come to me and go, can you teach me all the theories of addiction? I'm like, I can, but that's not going to necessarily help you engage people, right? You need to ask them what their theory of substances is, right? And then go from there. Stigma intersects with other forms of marginalization and oppression. I tell a story about a woman that I worked with in Coney Island. She'd fallen out of her HIV treatment, and we could gradually, over the weeks and months that we were working with her out in Coney Island, we could see her getting sicker and sicker. This was a woman of color who used drugs, who was a sex worker, living with HIV, hepatitis C. She was homeless. She had very little access to education. She was unemployed. She was a mother whose children had been removed by the system. How many layers of stigma is that for one person, right? So often what we're working with, and that is internalized by people. We are working with all those layers of internalized stigma. So when somebody comes along and says to you, they're just in denial, they should take more responsibility for themselves, right? Understand that what they're trying to do is get through all those layers to just get through the day. So understanding that when we're challenging stigma is so important. Muy importante. I'm also going to be an abuela at some point in the future, and I'm currently learning Spanish. Thank you to my Spanish colleagues in the room that are helping me. So when challenging stigma, we're trying to meet all people where they're at. So as a practitioner now, I'm not in direct service, but I'm doing capacity building. Today when I meet people all the time that are struggling with harm reduction, and I get it. In the 90s when I started, I questioned myself, right? I was someone who had multiple experiences of my own and other people's substance use in my life, but I still questioned, like, holy smokes, am I enabling people by giving them syringes? But I immediately saw when we started to do the work, the connection that providing that service from a place of non-judgment and suspended stigma, right, it connected people. Johanna Hari says the opposite of addiction is not sobriety, the opposite of addiction is connection. And that is what all of you are doing. That is why you were in this room, and I applaud you for that, right? Because that connection is what will engage people into services. So just very briefly, because we're going to invite our panelists up in a moment to share how they approach addressing this work and the stigma that they are helping people to address in their lives. But just remembering we have different forms of stigma. Individual stigma, right, where one individual is stigmatizing someone else. All those individuals come together into an institution and form institutional stigma. And that can be cultural, right, the culture of an organization. And I've seen this happen. People will say that they're harm reductionists, but their culture does not reflect it, right? So that's really important. We cannot just pay lip service to this. It has to be shown in the way that we engage, the way that we apply these concepts, and the way that we interact with people. I'm going to move to the bottom one. We then see stigma by association. So what I say is, at a time in people's lives when they need their friends and their families to support them, those same friends and families are also stigmatized and do not feel like they can show up in the way that they would want to. I was once working in a school before I came to America, I was also doing therapeutic group work with small children whilst I was working in the student exchange. And I'll never forget one of the school assistants saying, oh, no wonder that young girl's in your group because her mom uses drugs. And so she, you know what I mean? And I was like, she's in this group because her dad died of an overdose and we're talking about grief, right? But that little girl who was 7 was stigmatized by association, right? So imagine how that plays out. And so many family members have come to us and said, we wish we'd known about harm reduction because maybe our loved one would still be alive. But we were told not to have anything to do with them and let them hit rock bottom. But rock bottom for many people, and the stigma of that is death, right? And that's what we want to change. And then finally, we have stigma by association. So the person that's experiencing all of these things internalize it. And this stuff runs deep, right? Even our colleagues that have been doing this work as long as I have are dying because when they use drugs, they're still too ashamed to come forward and ask for help. That's how deep stigma runs. And so that's how we need to understand it when we're engaging people. It's not a simple thing to try and solve, right? Or help someone overcome. This takes time. It takes, you're unpicking decades of this. And then just key elements of stigma, right? The blame and moral judgment that people experience every single day because they're not conforming to what we are taught are social norms. Yet the social norms are to use alcohol and cigarettes that kill more people combined than any of the other illicit drugs put together, right? So just remembering that there is such a contradiction and hypocrisy in the way that we blame and judge people. The way that people are criminalized, either they're perceived as criminals or they're actually criminalized, right? So even when you don't have a criminal record, if you happen to use drugs, you're seen as one anyway. And then the pathologize and patronize, and this goes to the disease model, right? We patronize people. People who are told they have a disease don't always accept that label in the same way that people who have mental health problems don't accept the label that they're given, right? I have a cousin who's bipolar. When she found out, she was like, great, I now know what's going on, I can get help. My sister-in-law committed suicide because of the label of schizophrenia, right? Different people react differently to the labels that are put upon them, right? So just be really careful. If someone says they believe in the disease model, that's fine. But if they don't try and make them, right? Go with what works for them. And then fear and isolation. Stigma is a double whammy, right? Because we are taught to be fearful and to isolate people who use drugs. And people who use drugs are fearful of us and isolate themselves because of stigma. So it's a double whammy, right? That distance between them and engaging in services becomes really wide because of stigma. So this is the cycle of stigma that we've seen play out, right? People are stereotyped, there's certain expectations of them as people use drugs. That then means that we limit their opportunities, but people who use drugs also limit those opportunities themselves because they're fearful, right? And then that all becomes isolated. This is why you're here. This is what you're doing in your work, right? So I'm pretty certain that most of you are already working towards this virtuous cycle to interrupt the vicious cycle of stigma that people have been experiencing, where we use harm reduction to deepen and develop those interpersonal linkages. We create a climate of trust within our organizations that people feel like they can walk through the door and they know they're going to be received from that place of love and empathy and compassion. We are rebuilding systematic trust within communities, right? And we are creating this public health term that's called cultural safety so that we can bring about not just positive outcomes for people who use drugs as individuals, but also the communities and the families within which they live, right? So it's not just the individual impact of the work that you're doing, it's the community-wide. Right, and so when Bobby's walking through Kensington in Philadelphia, right, the work that, and Sean is here from Prevention Point, right, the work that they're doing in that community is not just about the individuals, it's about the overall health of those communities. So, and just a quick reminder of language, right? There's so many ways, again, this talks to the layer of stigma. There's so many ways that people get stigmatized and labeled, right? Just being mindful of all those different ways that happens and how that intersects. And then I'm just going to quickly say there are different levels of creating change, right? How do we create change? We can think about it at an individual level as a practitioner. What kind of languages am I using? How am I developing relationships of authenticity and honesty? How am I getting education and personal development? And I commend you for doing that today in this room by choosing this harm reduction track at the conference. We can also do it at an organizational level through the training, the feedback that we gain from our participants, asking them what they need. Is this working? Do we need to change it? What do we need to do differently? What's missing, right? And hiring people who use drugs. Don't just relegate them to being peers. They have they have more expertise in many cases than people. You know, yes, it's nice to get the pieces of paper. I wish I'd finished my master's. You know, I didn't, right? But I have a lot of experience behind me, and so do my colleagues who use drugs. Centering that, honoring that, and paying them for that expertise, right? Treating them equally. And then at a community level, how are we engaging the wider community? Do we form participant advisory boards? Do we community advisory boards? What kind of campaigns? What kind of imagery are we putting out there, right? There's lots of different ways we can challenge stigma. So I want you to go away from this session thinking about what are the ways that your institution could be stigmatizing people who use drugs, including harm reduction programs. My program was capable of doing that. We all have blind spots. right? But if we're aware of it and we look for it, then we can change it. We're all going to mess up somewhere along the line. We're human beings, right? What are the ways that people who use drugs might be responding to that stigma, right? How is that playing out? And don't just make assumptions about people's behavior because they use drugs. They may be responding to the way they're being treated. And what are strategies? When we do this as a training, we ask people to come up with 3 strategies. So start thinking about it now. What are the ways that you can change things within your organization? What are the ways you can change things within yourself, right? I say, we say in harm reduction, you know, we're non-judgmental. That's not really true. We make judgments every single second of every single day. It's important for our survival to make judgments, right? But by being aware of our judgments, we can differentiate between the ones that are positive and the ones that are not, right? So there's a ton of resources you can get. You will get these slides. You can go to our website. You can come and ask us for more. So I'm going to invite Carla from Coalition to Coalition in Puerto Rico, formerly of Intercambios, but now Rajni from Baltimore, Harm Reduction Coalition, and Will from the Bridges Project to come up and share some of their treasure with us. You look cute. Don't worry about it.
I know. Thank
You always look cute.
I know. Thank you. Both of them. Like I got everything on. I'm just like that.
So you see before you a powerhouse of harm reductionists, right? And they're going to share their treasure with you. I'm so grateful. So I'm going to invite, first of all, Carla to speak about... Carla, do you want to stand up here and show your slides, or do you want me to show your slides for you? How do you want to do it? You can come up here. So Carla, I'll let Carla introduce herself. Carla traveled in from Puerto Rico and developed a guide around addressing stigma for the programs there. And then we're going to hear from Rajani and Will about the local work that they've been doing in Baltimore for a long time to bring harm reduction and to challenge stigma in their community. Thank you, Carla.
Thank you. Buenos días a todos y todas. Gracias por estar aquí, la oportunidad de formar parte de esta actividad. Es la primera vez que estamos participando y estamos súper honradas de estar aquí. Van a traducirme porque me hace mucho más cómodo hablar en español estos temas. Así que, nada, espero que disfruten lo que pueda aportar en el proceso. So you need to translate or you need to translate? Okay.
Eso es ateo.
You.
Española es un poquito bonita, so
So Carla feels more comfortable speaking Spanish, so we're going to honor that, and I will be the person in charge of trying to interpret her brilliance, which is it's a high task. I will try to come as close as you, Carla.
Thank you. Como había compartido Emma, nosotros nos dimos a la tarea de crear una guía para proveedores de servicios porque entendíamos la necesidad de educar a quienes dan servicios para que no fueran una barrera a la hora de atender a las personas que van a buscar los servicios que tanto necesitan.
So Carla, when she was working at Intercambios, one of the things that they realized is that we're not exempt from stigmatizing people and becoming a barrier to people accessing services. So one of the things that they did was start working to develop this guide that was a guide for providers that are working with people who use drugs and potentially can be used with other communities, so we can reflect on our practice and catch ourselves when we are potentially engaging in stigmatizing behavior or using stigmatizing language.
Nos preocupaba mucho que la doctora Carmen Albizu llevó a cabo un estudio para medir cuánto estigma había dentro del equipo interdisciplinario que ofrecía servicios y los puntos iban de 0 a 200 y la mayoría puntuó sobre 100 entre 150 y fue algo que nos preocupó mucho.
So Dr. Carmen Albizu, who's a Puerto Rican researcher in harm reduction, has carried out a study with service providers working with people who use drugs. And the scale that she used went to up to 100, and most of the people that participated in that study hit that scale between 100 to 150, which is really, really high in terms of the stigma that they were projecting onto people. And so that was really concerning. We're people working in public health, right? And we shouldn't be stigmatizing people because we know that's a barrier. So to see that was really disconcerting, and that's why the idea for this guide came about.
Empezamos a ser parte de esto porque no necesitábamos solamente influir en política pública, que era el trabajo que yo hacía en Intercambios Puerto Rico, era además de tener la incidencia en proyectos de ley, en órdenes administrativas, cómo podíamos ir al campo donde realmente está la raíz del problema y no quedarnos en lo superficial. Y no es que las leyes no sean importantes, pero muchas veces no atienden directamente a las personas a quienes nosotros nos debemos, a quienes le damos servicio. Por eso fue también parte de cómo podemos incidir desde nuestros espacios educando, ya que la educación es como que una herramienta súper poderosa para poder transformar nuestras realidades y nuestras vidas.
So this guide wants to address the ability that we have to learn from each other, to engage in self-education and community education. Sometimes, when we think of changing systems, of changing stigma, we think about public policy, right? And it stays up here, but how does that permeate and filtra? How does it get down to the practice? En español se dice, ¿cómo se comen arroz y habichuelas? How do you eat that with rice and beans? How do I take that theoretical thing and make it into a practice, right? And so the idea for this guide was that. It's like, it's great to have these conversations at these high levels, right? Whatever that means. But what about us doing this work? How can we get that information and education, then turn it into a practice?
La guía no tiene la intención de regañar o decir estás haciendo esto mal o estás haciendo esto bien. Es poder crear una conversación abierta, honesta, entre proveedores y participantes. Que no es como que vamos a decir nosotros tenemos la razón, sabemos lo que hay que hacer y ustedes sigan la instrucción. Realmente eso no era lo que queríamos, no era el propósito de la guía. Era crear conversaciones positivas, abiertas, de confianza, en donde realmente pudiéramos conocer a la persona, que fueran mucho más humanas y poder ayudar y proveer los servicios que necesita o la ayuda que necesite.
So the guide was also not meant to shame and stigmatize us as people, right? As we know, any positive change, we live in systems that teach us to stigmatize and shame people, right? Like that's what the systems do. So you cannot, it wouldn't be productive or helpful for a guy to be like, you're a bad person, right? We didn't want that. What we wanted to do, or what they wanted to do, I'm including myself, yes. Was to create a space for people to engage in reflection, in conversation, and to build trust, right? Which is so important. And also to really listen to why people are using certain language, particularly participants. As Emma was saying, sometimes we use language because it feels empowering to us. And in harm reduction, I can say, for example, or I've heard people say I'm an addict, right? Like that makes sense to them. And the goal of this guide is to help people be bilingual, right? It's when you go into court, because you have to see your probation officer and you use the word addict, what does that bring up for that person? Is that person able to make the translation in their head? No, maybe not, right? So what we want you is to think about maybe using other language that doesn't attach that label, because here in this harm reduction space, you're safe because I understand. And what I want you to, and what we want participants to do and providers is to be able to be bilingual, to make that shift and translation in their head.
I skipped this one. La guía es fácil de usar. Volvemos al rojo, amarillo y verde, como hacíamos en kindergarten. Rojo, pues no se debe utilizar. Amarillo, podemos trabajarlo siempre y cuando la persona se sienta cómoda del término. Y el verde, pues es realmente lo que deberíamos estar utilizando porque es un término neutro, no es estigmatizante y nos ayuda a tener unas conversaciones mucho más productivas que poniendo unos títulos o unas palabras que realmente lo que hacen son cerrar las puertas.
So the guide is color-coded. Red is language that we may want to pause, stop, and think about, wait a minute, this carries a lot of weight, right? What does this mean? This is language that maybe is outdated, that is stigmatizing, right? So we may want to sit down and consider, not using it, and why, right? The why is important. Then there's the yellow, which is language that we can work with. And then there's the green, which is the language or the terminology that is preferred because it's neutral, because it's language that doesn't hold stigma in itself, because it is language that we want folks to start learning and using more.
¿Qué se puede encontrar? ¿Cómo hicimos la guía? La guía tuvo participación de participantes a los que ofrecemos servicio en intercambio. No fuimos nosotros desde nuestro espacio de privilegio diciendo qué eran las palabras. Realmente hicimos varias entrevistas, preguntamos con qué palabras se sentían cómodos o cómodas, con cuáles no, para entonces desde nuestra realidad en Puerto Rico y en nuestra área geográfica particular donde ofrecemos servicios, cuáles eran las palabras que estaban siendo problemáticas para que las personas no pudieran llegar a los servicios que necesitaban. Y pues también hicimos revisión de literatura para poder validar toda esa información y que tuviéramos un documento que la gente respetara, que la gente entendiera que no se hizo a lo loco, que nos dio la idea de trabajarlo, sino que teníamos validación tanto académica, científica y de la comunidad a quien va dirigido el proyecto.
So this was a participatory action research project. Program participants were involved in the development of this guide. They led this process. It is also important to acknowledge that this is a guide that was designed and developed with language that is used in Puerto Rico. So when we ask participants which language you find problematic, it's language that is used in the island, right? And so that is important to note. And although, the expertise and the knowledge of participants was what led the development of this guide, sometimes we know that, people don't really trust that. And so folks that developed the guide also did literature, ¿cómo se dice eso en inglés? Ay, Dios mío. Literature what? Literature, when you review the literature that other people have written in academia, whatever that means. Exacto, eso mismo. Perdón, no sé, es que me tranqué. So, to just show, okay, other people are also naming this, and there's this research here. If you don't believe us, you can also look at this. But we know sometimes it's not about, it's not the literature, they don't believe us because, it's about shame and stigma again.
Y utilizamos modelos como Australia, que está en el slide, y Colombia, que no hay que inventar la rueda, ya hay trabajos que se están haciendo muy efectivos y pues decidimos entonces utilizar estos dos modelos que han tenido muy buena acogida en la población y han logrado disminuir las barreras en cuanto al estigma cuando hablamos del lenguaje.
And through the revision of literature, we found models from Australia and Colombia where they already been doing this work. And so why reinvent the wheel, right? When something is already there, it's about, taking what works and with permission adapt it.
¿Qué podemos encontrar en la guía? Empezamos en entender qué es el estigma. Muchas veces nos comportamos de unas maneras y no sabemos que estamos siendo estigmatizantes porque es lo normal, es lo que nos hemos acostumbrado a hacer todo el tiempo y no nos los cuestionamos. Que entonces empezamos a hablar qué es el estigma, mencionamos los ejemplos que presentó Emma anteriormente, para entonces saber qué estamos haciendo y cómo podemos mejorar. No decir, estás haciendo algo mal sin darte una razón. Siempre pensamos en la educación, pues como he mencionado en muchas ocasiones, es una herramienta que nos libera y que nos ayuda a entender y cuestionar lo que hacemos todos los días.
So the guide starts with understanding what stigma is by engaging participants that are reading it in a definition of stigma, the different types, and then that's it, yeah.
Definiciones importantes según los conceptos que nos habían traído las personas, los participantes que colaboraron en el desarrollo. Decidimos entonces buscar la definición de qué significan las palabras, cómo se come esto en arroz y habichuela, como dijo Tanagra. Identificamos pues las 19, estamos hablando de que es reducción de daño, estamos hablando de persona que usa sustancia. Todas estas palabras que muchas veces son problemáticas y la gente no sabe qué significan, pues también trabajamos las definiciones.
So they also identify 19 words in particular that we found participants name people struggle with, and then they defined those words with the aid of participants around harm reduction, about person who uses drugs, right? Those definitions came from participants, and they're rooted in a harm reduction framework and lens.
Y como no podemos olvidar que esta guía va dirigida a proveedores de servicios, quisimos hablar del uso de sustancias psicoactivas. Muchas veces, o por lo menos en el caso de Puerto Rico, tenemos proveedores de servicios que no saben cómo son las sustancias, cómo intervienen en el cuerpo humano, y para nosotros era importante entonces hablar de las sustancias, cómo se dividen, qué efectos tienen, y toda esa información también la trabajamos.
It was also important to acknowledge that we don't get any drug education at all, not in Puerto Rico, not in this country, and so what we know about drugs is not rooted in science, is not rooted in evidence, and so they decided also to have a chapter that speaks to psychoactive substances to provide folks with an understanding of, like, if someone is using heroin, why would they be using heroin? Why is this drug good? What does it do? How does it work? And why would I seek it, right? So that then folks can start asking questions from a place of building rapport. Okay, I hear that you're in physical pain, then it makes sense for you to be using heroin, for example. I hear you're emotional pain. It makes sense for you to be using heroin. You need to work a double shift. It makes sense for you to be using meth because it's really great at stimulant to keeping you up, right?
Aquí les presento una imagen de cómo están las definiciones importantes y otra imagen de cómo presentamos los tipos de droga.
So these are some images from the guide in terms of the important definitions, and this is over here on this side, it's the kinds of drugs and how it's laid out for folks that have access to this guide.
También pueden encontrar cómo vamos a trabajar para eliminar el estigma. Aquí pues también utilizamos 18 conceptos que identificamos mientras estábamos desarrollando la guía, que se utilizan frecuentemente en los espacios donde las personas buscan servicios, y ya mismo les voy a enseñar una imagen. Hicimos una tabla con el concepto, el rojo, que es lo que no se debe utilizar, el amarillo, el verde, y por qué estamos recomendando que se utilice el verde. Volvemos, no queríamos como que imponer nada, porque entonces estamos haciendo los cambios, está todo en esa tabla.
Also gives you tools and things that you can actively practice to challenge and question and change stigma. And Carla is going to show us in a minute a graph that shows how this is found in the guide.
Y la otra parte, y no menos importante, cómo deben ser los servicios a los que las personas van a buscar la ayuda que necesitan, que sean de bajo umbral, que estén basados en derechos humanos, y todos los conceptos que vamos a estar discutiendo a lo largo de la tarde, que son importantes, también lo traemos porque queremos darle la información a los proveedores de servicio para que entiendan, conozcan y estén evaluando por dónde se están moviendo, y entonces puedan mejorar si es que hay que mejorar, o puedan continuar ofreciendo los servicios como lo están haciendo.
And there's also an opportunity for people who have access to the guide to review their services to see if their services are low threshold or where are the barriers that folks may be facing to access services, and also recommendations and suggestions, not only how to do that, but also how to shift and change your services or how to build services that really meet the needs of people who use drugs and program participants.
Y la última parte es un checklist donde nos vamos a evaluar si realmente estamos moviéndonos a eliminar el estigma.
And so harm reduction loves self-assessment. So the last piece is a self-assessment that helps you to see where you're at and what are the things that you can do to move yourself to eliminate stigma in your practice as a person and hopefully also in your community.
Ahí pueden ver entonces un bloquecito de cómo están los términos, y este es el checklist, son varias preguntas y pues la lees y evalúas si estás haciendo las cosas como se supone. Entre una de las preguntas es: ¿cuentas con información actualizada sobre el tratamiento para trastorno por uso de sustancias? Y se hace esa pregunta particularmente porque en muchos espacios seguimos utilizando tratamientos que ya no son lo que se utilizan, y no, los médicos particularmente no están actualizando. Se piensan que el uso de sustancias es un tema moral, y no necesariamente que tenemos que educarnos constantemente para poder mejorar la calidad de nuestro servicio.
One of the questions in the checklist is, do you have actualized information that can help you understand or address substance use disorder or why people use drugs, right? Particularly in clinical settings, in medical settings, some of the information is not up to date. People are not necessarily engaging in continuing education. So this is something to remind us that things change, as Emma said, you know, and it is important for us, if we want to serve people with dignity, with respect, with care, that we have to engage in our own education. We have to seek out those resources and recognize when we need help, right? When we need to learn more.
Gracias. Y aquí pueden descargar la guía. Está en español al momento, pero a lo mejor en un futuro cercano estaremos poniéndola en inglés.
If you want to fund Carla and the group that created this guide to translate it from Spanish into English, talk to her, because now you're going to scan that, but it's going to be in español. Si no hablas español, you may not be able to use it, but if you are interested and want to support, Carla está aquí, you can talk to her about hopefully, you know, getting some funding for that.
Gracias.
Thank you so much, Carla. Carla is a powerhouse, right? I wish I'd had that guide, right, a long time ago. So I'm going to make an executive decision, if it's okay with the organizing committee, to run over by 5 minutes, right, so that we have enough time for Rajani and Will to share their treasure. Rajani's got some slides. She's going to walk us through what's been happening in the history in Baltimore, and Will's going to tag team with Rajani, and then we'll go for a break. So 20 more minutes, and then we'll go for a break.
Good morning. Take this off. Oh, wow, so many people. It's so early. I have my bachelorette party here. It's just really weird to be in this hotel. You have no idea. I was like, wait, I remember that pink poodle thing. And I'm like, barely. Okay, hi, I am Rajani. I use she, her pronouns. I am a co-director of Baltimore Harm Reduction Coalition, and I oversee, and I oversee our mobilization work. So mobilization is basically our community organizing and policy advocacy work. And some of these slides are a little outdated, I'll be honest in saying that, and I'll explain a little bit why. Context, you are in Maryland, welcome. You are in Baltimore. Maryland facts is that overdose has been a crisis here for far beyond when the United States had decided to start paying attention to it. The overdose fatality rate has consistently been above the national average for more than 20, 25 years. That likely goes further back, but they really only started paying attention to overdose data in the early 2000s, to keep that in mind, around the time of more white people, which we'll get into. It has ranged from roughly 1.5 to 3 times the average rate, to really think about it. And this is a little outdated, but over 25,000 people have lost their lives to unintentional overdose in the state of Maryland. No county has been spared from this in the state. Baltimore City has had the highest rate of overdose in the state of Maryland. Baltimore County and Anne Arundel County is where our capital Annapolis is, for context. They have had the highest. So that's sort of context on this little state, right? What impact overdose has had here. Now this chart I always use and will always use until the Maryland Department of Health gives me something updated. This is from 2020, okay? But this is the very first time in my almost 10 years of work in overdose prevention in this state, and many of my elders also had said this is the first time we ever really saw a data snapshot from the health department, who's very cautious about how they share demographics about overdose, particularly when it comes to race and ethnicity. It's the first time they really admitted, it says there where the arrow is, from 2017 to 2019, overdoses decreased by almost 11% among white Marylanders and increased by about 35% among Black Marylanders during that period. That's stark. This was in a, thankfully we have interns and we have staff who will go through these bureaucratic reports, right, to find things like this. This was not something that was a big report that was sent out. This was found in the depths of a report that we keep showing, and we're asking for more data. Is this still true 3 years later? How has this changed? What are we doing about it? The answers to that are likely disappointing, right? I really just am so honored to be here in this space with the National Harm Reduction Folks, Tanagra, Emma, it's beautiful. And they were talking about how these definitions, these terminologies, Carla was saying, we take the terminology, we have to understand it within context. So what we did at Baltimore Harm Reduction Coalition when I first started in 2017, my co-director Harriet Smith and I had both come to BHRC from Baltimore Racial Justice Action, which is a local training group that does education and training on racial justice and ending anti-Blackness. And what we learned from there about systemic racism and what we've learned from NHRC around the different ways harm reduction shows up, in kind of focus group space, we put together these definitions of harm reduction that make sense for us in this context, individual level and institutional level. And I could read the words out. Individual level, harm reduction expands choices, increases access, and promotes opportunities promotes opportunities to be assisted and assist others to increase safety when engaging in drug use and sex work. So we're talking about these tangible interactions. And some additional pieces I wanted to add that individual also means internalized, what we think inside our heads about ourselves. So when we're thinking about stigma, when we ask patients and clients, what do you want to work on? Opposed to, I see that you're using drugs, do you want to work on that? You see how those two questions are different? Right? Because often when we name the drug use of someone else before they do, that kicks off that internalized stigma hard. Oh, you're right, actually that is something I should work on, and you're right, I am this or I am that. It's a very different interaction. What do you want to work on? Just every time, right? We have built-in shame that is usually supported in typical client interactions. And particularly when we have billing to think about, when we are FQHC organizations that are thinking about insurance. I know, I get it, listen, I get it. And it's not doing anybody good if we're thinking about it from that place. So in order to do at an individual level, what can you do even though you are within a federally qualified health system? What you can do as an individual when working with patients is ask them what they want to work on before trying to find a diagnosis for them, before trying to disorder them. Learn from them first, and then work from there. Then we have the institutional level, which harm reduction shifts organizations, systems, and our broader culture to be safer for both individuals and communities, focusing on how we can increase safety by improving the context in which drug use and sex work take place. Context is environment, neighborhood, racism, sexism, hyper-policing, police violence, fear of police violence. That is all part of the context. And I say all that very clearly in Baltimore City, which has an extremely violent police department who is actively going after people who experience drugs and people who are homeless. And people anywhere that they might assume are attached to either of those. This is one of the reasons why we're connected in this work, right? We come to, and often our organizations, because harm reduction has become this term that we all understand, it's become a hot term because we get it. We get why it's a big deal, a lot of us, at least you chose to be in this space versus the other big rooms today, right? So you understand why harm reduction is important. And what we need to do is think about not how harm reduction can be a lens that you can add on top of how you do your work, right? Often when we've experienced, we do a lot of partnering. At BHRC, we partner with a lot of organizations in the city to strengthen our systems. And often when we do that work, we come across organizations, particularly when federally qualified health centers, who want to overlay harm reduction onto their standard values. You come in with something and you want to overlay harm reduction in that. Harm reduction then ends up becoming a drop in an ocean. We want you to rethink the ocean. That's my analogy for today. Rethink the ocean. Completely shift how you're thinking about disorders and billing and everything, and harm reduction is giving you a new understanding of that. That's what we're asking people to do. Society and the systems within it have historically increased harm to people who use drugs or engage in sex work through oppressive policy and stigmatizing culture. That is why we do this. So I wanted to give that lens on how we approach these definitions, because it's also a model for how your organization can take definitions and make it make sense for you. So our community mobilization work, the reason why, so I should actually say we're the first community-based, Baltimore Harm Reduction Coalition, my bad, is the first community-based organization in Maryland that became a syringe service program. And so we do syringe services. We were the first to become a naloxone distributor as a community-based organization. Organizationally, I'm not talking individuals. There are individuals here, Will Jr. is one of them, who have given out these services and doing these services. I'm talking institution with a certification with the state as an institution to do this kind of work. And so that is a lot of what we do is service delivery. But we made sure to keep doing community mobilization, which is not funded by the state, right? So we have the Access program, which is a grant fund through the state health department. We are very lucky to have that in Maryland, / that should be a standard for all states, for there to be a Center for Harm Reduction Services that funds community-based organizations. We get private foundation funding to do organizing because harm reduction is political. The programs and policies that save lives do not come out of thin air. Governments do not make policies or invest in programs to save lives unless they're pushed. If we want more harm reduction, we need to fight for it, and we need to fight very hard. This is kind of a history of how harm reduction programs and policies have been set up over years in Maryland. So one of the most beautiful things that is true about where you are is that 1994 was when Baltimore City, state legislation passed to start pilot needle exchange program in Baltimore City. So it's been run by the city health department since 1994. It's still running. They have a couple of vans. They go out and they do amazing work. It was the only needle exchange program in Maryland, okay? And some bordering states. 1994, you see that jump? 2016, that's whole adults, right? That is a whole adult life right there. Maryland, then in 2016, Maryland law allowed all jurisdictions to set up syringe service programs. So what that means is it allowed community-based organizations to open up these programs. But wait, did we have any protocol for this? Was anybody saying, yes, go ahead and do it now? Absolutely not. So then we have administrative policy, all the bureaucracy to do the paperwork. That is one of the things that makes it really a struggle when you're working with the government, to be honest, right? Like we're saying, we would rather be able to define what this looks like to speed it up. And I'm not trying to hate on the government. I'm really happy the Maryland state government. Please don't cut our funding. My hair is going to be mad at me. All I'm saying is you see how it was 2016 and then 2018, 2 years later, we finally were able to have an application process for community-based organizations to be able to apply to become certified to do syringe services. At that point, then 2 Baltimore City organizations applied. That's BHRC and I think Charm City Care Connection, shout out. And now we have 22 syringe service programs around the state. That's amazing. And it's a lot run by local health departments in areas that are very remote, very rural. Our state is so rural to urban, such a wide variety. And so it's a lot of rural-based local community health programs that are providing syringe services. And we have the naloxone access timeline there too, but I'm gonna kind of move past that and just say we have naloxone accessible in the state. Anyone can carry it. If you want any, let us know. I'm sure people can get you naloxone here. And also we've been working, it doesn't end there. Naloxone alone is not gonna solve this overdose crisis. Naloxone alone isn't gonna do it. There are things that we can make it easier. For example, having a better Good Samaritan law, that would help. And I would love to rail about the Good Samaritan law with you. I will do that at another point. Let's just say the Good Samaritan law in Maryland has existed for a few years, and it was just a few months ago that we finally got an inch to expand it to actually cover the person experiencing the overdose. I'll let that sit for a second, but please use naloxone if you see somebody experiencing an overdose. So, adding the new to the old or well-established, this is where we move forward. Maryland's community-based syringe service providers can give people safer drug use, tools, education on safer injection and or safer snorting techniques. We can sit with people and provide respite, and they can let their guard down, they can chill. These are things we are legally allowed to do and that we do very well. And by we, I mean this whole spectrum of harm reductionists that exists in the state. Our whole infrastructure is really based on being able to do that work. We can do so much, but we can't be with people, sorry, there's a typo. We cannot be with people when they are most vulnerable, when they are actually using the drugs and the moments right after. That is where partnership and communication and pushing gets more into play. You're gonna get this slide by a shirt. Decriminalizing paraphernalia is extremely important, but for sake of time, there's two bills that we've been working on in the harm reduction work here in Maryland. One of them is to decriminalize paraphernalia so that people can carry supplies in the state. To be clear, if you are a syringe service participant and you carry a card that is like a get 10 ice creams, buy 9, get a 10th free kind of card that's flimsy, that's what the participant card is like. So if I lose mine or have like 7, right, when you're like, oh, I forgot my card, you have to get more. Imagine when you are unstably housed and you have to carry this around in case a police officer stops you, and then that police officer has to then give a crap that card is in your hand and actually treat you right and say, oh, actually, you are legally allowed to carry that. Go about your day. That does not happen. That absolutely will not happen. So that's why we need to decriminalize paraphernalia so that people can carry their supplies, whether they can prove they're a participant or not, whether they're giving those supplies for their loved one who couldn't make it to the syringe service program. So that's what decriminalizing paraphernalia is about. We need to get that in Maryland. If you are a Maryland resident, I would love to yell about that with you and why you can help us get that bill passed. I will throw it over to William Miller Jr., who we co-founded, along with a few others, the Bridges Coalition for Overdose Prevention Sites. Because I'm a slide person, I'm gonna just throw some slides at him. Bridges Coalition is here. It's a beautiful place. Local Healthcare for the Homeless, shout out Molly, Joanna, is a member of the Bridges Coalition for Overdose Prevention Sites. And it is dedicated to legal authorization and community-led implementation of overdose prevention sites in Maryland. We started the coalition in March 2017. We do community cleanups. This is a picture of us going to On Point NYC to learn. Who you don't see in that photo is Mayor Brandon Scott and a few city council members. I think that was the tour they were on with us. And we go to the state and we have testified in Annapolis, I think, for 7 years to get the state to authorize these bills. We have a Yes on My Block campaign, which is beautiful. You'll see Junior and his beautiful baby in there somewhere. And the Yes on My Block campaign, if you are a Baltimore City resident, please ask us about it. It's basically a petition to say, yes, actually, people do want overdose prevention sites on their blocks. This was in response to a senator who said to us, okay, sure, the evidence is there, but no, you can't say any of you would want this on your block, which was really just like, you know what I mean? We were all like, oh, cool, I get to yell something in a microphone now at a bill hearing. And 30 people all said, yes, I would want this on our block. So that is a campaign we have. We have a petition. If you are a Baltimore City resident or know anybody who is a Baltimore City resident, please sign that petition. It'll go to our Baltimore City legislature. And for that, I leave it to you. I'll leave this picture up.
Now a round of applause for Reggie, please. I'm not that eloquent. I'm not going to stand. But my name is William G. Miller Jr., and I always make sure I put emphasis on a junior. There was a senior who's no longer here, and actually in the picture, the Yes on My Block campaign, actually with the mayor. No, that's right there. William G. Miller III was born a day after my dad passed, which some of these numbers we get from the state now, my dad was a part of those numbers. So I take that in stride. It was kind of hard, but it was like helped me grow a lot. So been doing harm reduction for some time now. And as Resney spoke about, it's been a lot of collaboration with things. One thing I'm proud about is knowing how to disseminate the information that I receive about harm reduction. And one thing I always like to emphasize is what harm reduction is not. Because sometimes we get limited when we hear the word harm reduction. And me being a person with living experience, and some people only recognize people with lived experience is a difference, and I can break it down to you later, get a little alienated sometimes because some people believe harm reduction means anything goes, and it doesn't. And you need to know the interpretations of it. So with that said, I'm going to bring it current. Reggie brought something up 1994. 1994, I was on my way to another residence in Maryland, which is called Division of Corrections, meaning I was incarcerated. But Baltimore City was the city that reads. It was the city that reads at one time. Mayor Kirk Smoke, who I always talk about, was very imperative about legalizing all drugs at one time. He was the reason behind the syringe change becoming a syringe change in Baltimore City. And it was a lot of things put in a box, I think outside the box a lot, because everything that was put in the box wasn't working. So we had some people that say, this mayor is crazy, literally. But this was almost 30 years ago. Now we current. And we working on our, the Bridge Coalition, working on, and we've been doing it almost 7-8 years, of trying to get overdose prevention sites, meaning where someone will have somewhere to go, like, and we always talk about the drug use, but I always put emphasis on other things. We can go to a Starbucks and get, I'm not disrespecting no one, Starbucks or anything, but we can go there and get Wi-Fi. But some of the people who was unhoused, who are using, or you just don't like how they look sometimes, unable to go in a Starbucks and get Wi-Fi, so we can get some of the adequate services that does exist, but it's barriers to that. One of them being like the technology. But if overdose prevention sites, which people who love people, who care about people, that's already doing the work, will be able to provide Wi-Fi. That's how I break down my way of the harm reduction things, because people don't look at certain things and always like to hear, oh, I didn't look at it that way. Sometimes people don't look at all. And it's about how we get this. I always bring up water. People, what about water, you know? When people inject, maybe snort, however they use drugs, we need water. And they will use any kind of water. My dad once told me, and I know he did it, son, I'll use rainwater, right? That's cool, but it's not healthy, right? So we can get water now. Now, what kind of water to make you feel good? We all woke up this morning, because we're here, but I was able to take a hot shower with hot water. And some people don't understand the significance of a holistic approach of how we treat our communities and how we treat our communities. So by doing this work, it helped me to heal because I was struck by a tow truck in 2015. I have a lot to be upset about, but I had a lot to be thankful for too. And by doing this work, it's not about me. It's not about like who I'm working with. It's about the people that I'm servicing, the communities I'm trying to uplift, and about the issues that's breaking my community down. And it's like voting for me. I'm not voting for you because of what side of the aisle you're on. I'm voting for you because you see some of the same issues, well, you're talking about anyway. Sometimes they be, what they talking about it, but I vote for the issues of that's not talked about, that's being talked about openly now. And harm reduction is a very touchy subject if you're not able to like interpret it or get the correct answers and have it broken down into ways where as though, oh, I see your point. Because it's fine to have a legal drug, which is some people like red wine. Not talking about people who like red wine. However, we have a liquor stores almost every corner. It is legal. Something I learned from Reggie. Prohibition and how things was added up and through and just fun facts, history. It's a lot of history in Baltimore. And where I grew up at, Pennsylvania Lafayette, they have a statue of Billie Holiday. Billie Holiday. It also was like a little strip where everybody used to go, hang out. Red Fox, Sammy Davis Jr. They used to go gamble. But in 1968, there was a riot, and it messed that community up. And we don't have to talk about the events that happened in 1968. However, it's underserved people who are influential that never get brought up in these conversations. But on that day that they had these riots, they called a known drug dealer to stop the riots. His name was Little Melvin. And he had enough power to tell the citizens of Baltimore City to cut it out. Stop burning down town. Billie Holiday was targeted because of her freedom of speech and a song called Strange Fruit. Just show Jose the picture, and they have it on there. However, I grew up in this area, and until I started doing this work, I never knew the history from behind it. You know, so along with education, and I always try to make sense out whatever I'm doing. Whatever I'm doing, I'm trying to make sense out of, like, why am I doing it? And the reason why I'm doing it, because my community has been impacted by this. Not even knowing it. So the work I could continue to do, my dad, I have a 14-year-old daughter. My son, who's 2.5, and I recently have a 6-month-old child. That it's imperative that I keep moving, keep educating, and try to be the best community member that I could be. Because it's all about community. Everyone in this room is a part of some community. It's not about a solution all the time. It's about going towards it the right way. So with harm reduction and the work that I've done to bring it back to like our mayor now. 30 years ago, and we got a lot more room now with our mayor of Baltimore City. Some people may not think it is, but we have one-track mind, so people have one-track mind sometimes. But it coming to light that the issues that, like over the years, that we push for, going to New York, going to Puerto Rico for this last conference, and then the healthcare for the homeless. The reason why I like healthcare for the homeless, to me, everything that you need, you can get it from them. And I know a few people that actually use those services, and they don't judge. The thing that you need, they work with you. And they don't ask you why you don't want to do something. And that's a barrier sometimes for people asking. People with lived and living experience, going through certain things, making assumptions about them, it really causes more harm when you're not knowing exactly how to engage with a person, and that's the key. Engaging with people the proper way. I like to know people's names when I do outreach, and I did outreach around all Baltimore City. So with that being said, I just appreciate being able to have this platform in my city. And the reason why I had this platform, because I was able to build some real meaningful relationships, not only with people in organizations, but I still had these same relationships with these individuals that you may walk past or ride past with a sign up. I know some of their names. And until a person know what somebody's going through, let's not assume and judge, because that's how my dad passed. Because he was hiding from using. Stigma, people being judgmental. And he was at his best, doing great, doing wonderful. But that stigma, those labels that attach certain people, it can be really devastating to a family. And I always think outside the box. You never know how many people can be affected by that. Thank you.
So I lied to you, right? We went on a little longer, but I am so grateful and honored to have shared this stage with these amazing people, and I think it was worth the extra time. Will and I, yeah, right, another winner of both. Will and I have known each other many years. We trained together in the early days of this, I think 2015 or 14, way back when, right? So, so please go take a break and come back in 10 minutes. Thank you.
Welcome back, everyone. Welcome back, please. We're so excited for our next panel. We're going to talk, this next session is going to focus on federally qualified health centers and syringe service programs. So I'm going to turn it over to Barbara DiPietro, the Senior Director of Policy at the National Healthcare for the Homeless Council. Barbara?
Hi, everyone. If you can hear my voice, clap once. If you can hear my voice, clap twice. All right, excellent. We are going to start an exciting panel here on FQHCs and SSPs, an acronym soup if there ever was one. Hi, I'm Barbara DiPietro. I'm the Senior Director of Policy. I'm here just to orient to the framework of health centers before we get to a really great discussion with a panel of folks who are doing this work. So let's see if I'm... very good. Back in October of 2021, HHS Secretary Javier Becerra came to Healthcare for the Homeless Baltimore and declared that harm reduction was a key pillar of the administration's overdose prevention strategy. And this was the first time, not even 2 years ago, that the federal government was comfortable saying those two words together, harm reduction. And that was a huge policy step, sad to say. After he did this announcement, he then went on a tour of our facility. And that included a visit to our harm reduction suite, which Molly Greenberg here oversees, and you'll get to hear from her. And he saw firsthand the work that we do to provide our patients and our clients with clean syringes and other supplies. And I found out later that the Secretary for Health for this country left that site visit having a better understanding of what harm reduction looked like in practice, not just words. So again, the importance of site visits and engaging your elected and policy-making officials. So this panel is focused on how we can do more of that work, how FQHCs can maximize being an SSP or partnering with an SSP, and how we put the policy into practice. So I'm curious, how many people here work in an FQHC, in a health center? All right, awesome. How many people here are working in an FQHC that is not currently doing syringe service programs? How many people here are working in an FQHC who really want to do syringe service programs? Fantastic. All right. So I work for the council, but I'm based at the Baltimore HCH, which is why I know Molly so well. And I am a big fan of health centers. I've been there for 14 years. The health center program has been around for 50 years. And what started as a small program is now 1,400 health centers nationally in 15,000 locations serving 30 million Americans. Primary care and support services generally. And so first, what I'm going to say today is why I think health centers are absolutely the right organization and the right type of model of care to be an SSP or partner with one. But I'm also going to talk a little bit about how FQs are challenged to do this work and what you can do about it. So let's skip to why do health centers make great SSPs? So you'll see here a picture from that same press conference with our former CMO, Adrian Trustman, and our current CMO, Laura Garcia, showing off for the secretary and others the kinds of services and supplies that we provide to clients who come to our facility. FQs offer a wide range of services: comprehensive primary care, support services like health education, translation, outreach. It's easier for patients to get their care in one place rather than running all over town. 2, FQHCs provide care regardless of insurance status or ability to pay, which is a really important piece in American healthcare system. 3, FQs offer care that respond to the unique needs of a diverse, medically underserved area and population. Now, the term underserved irritates me because who underserved them? It's a passive term that puts the onus back on the policies that create underserved populations. So just a note there. Separate workshop to talk about that. Also, FQHCs are required to include the patients in their governance. Health centers are supposed to offer their services at patient demand. So if your patients want SSPs, then your health center should be an SSP. Also, health centers are highly regulated spaces with credentialed healthcare providers. And they've got peer specialists, community health workers, all of the people that make this work well. They're poised to administer these additional services and do outreach to vulnerable people. They're part of the core mainstream healthcare safety net. They carry a lot of credibility in the community in which they are located, and they often have the ear of the policymakers in your community as well. And finally, health centers were founded on just the basis of social justice, of delivering care to people who specifically had been left out of the system. So that's why health centers are awesome for this. But let's be honest, let's have an honest conversation about where health centers are also challenged to do this work. So one, federally qualified health centers, they've been traditionally focused on just primary care, often to the exclusion of other services like behavioral health. So for a long time in the entire healthcare industry, and really still today, behavioral health was something separate. You know, those were services that other people needed from other types of providers, right? So healthcare for the homeless health centers are required to offer substance use services, but that's not true for all health centers. You know, I had one doc from Kentucky tell me once that he got into primary care to treat diabetics, not addicts. And I thought, well, you must be Clinician of the Year. So pleased to meet you. Number 2, health centers are mainstream. They do have credibility in your community, but sometimes they're so mainstream, they're afraid to step out of the box. 3, Some health centers are afraid of doing anything controversial, lest they anger a policymaker or a community group that's going to frown on what they're doing and set up some kind of protest outside their doors. And frankly, some are not very engaged in medications for opioid use disorder, which is a gold standard of primary care to begin with. So health centers have work here to do. Frankly, even if a health center was wanting to do an SSP, was wanting to do this work and bring something up, they're overwhelmed with competing priorities right now. New funding approaches addressing maternal health, children's health, complex care coordination, chronic disease management, expanding into food assistance and nutrition. All of this is righteous work, and to be honest, it doesn't bring any of the eyebrows, right? Oh, the pearl clutching that might come along with doing SSPs, right? And then finally, it's not always been 100% clear for all health centers whether they're even legally able to do SSPs as part of their work. And so that's changing over time. Federal policy is now clear. However, health centers are going to be conservative in their programming. They're not going to want to do anything that's going to cause them to get an audit finding or potentially be shut down, and then no care can be delivered. So the good news on that, and I'm really excited to announce today, HRSA, our governing, our funding body, the Health Resources Services Administration at HHS, they are literally in the process right now of posting new guidance that very clearly says health centers can be SSPs, and here's how. So we are looking for this to be posted anytime. Okay, what you can do. Health centers, in my opinion, they have an obligation to do this work. It's clearly part of the mission. It's clearly a need of our patients. Talk with clinical leadership, because they're the ones who are likely to be the strongest internal champions for getting an SSP at a health center, it's the clinical folks. 2, illustrate how SSPs help quality outcome measures and are connected to the access goals that we're all tracking in health centers. 3, use the new guidance that HRSA has posted to reassure health centers that this is legal and appropriate. 4, encourage patient leaders to leverage their consumer governance role in pushing for the services they want to see. Encourage your health center leadership to connect this work to their equity goals. Now, all our organizations are rolling out with all kinds of statements and plans. What's that really look like in practice in your equity work? How are you monitoring this? How are you targeting this? How are you driving down the healthcare disparities that are causing more black and brown people to die in this country every day? There's a lot to say there. Invite public officials on tours. So I mentioned this before. Facilitate discussions between public officials, people who use drugs, and the providers that serve them. Facilitate those learning and honest discussions that people really want to have. And then finally, constantly engage, constantly do relationship development. We all know that even just changing one position within an organization can somehow change the culture, change the programs, change the possibilities of what can move forward. So never give up and engage in that development there. So finally, before I hand it off to Dr. Rodriguez, frankly, as the policy director, I am compelled to say that if you're in this room, you're part of a bigger community than just harm reduction. You're part of a community that's putting the values of dignity and respect and compassion and justice at the core of your work. I don't know if you've heard, but there is a widespread concerted effort in this country to take healthcare away from people, housing away from people, food assistance away from people, human rights, civil rights away from people. Encampments being swept every day without any regard to the health or well-being of the people that live there. Black men being lynched in this country almost with impunity. The most recent one, Jordan Neely, his killer now called a hero. That ain't right. That ain't right. If you are in this room, you are part of a bigger community that is doing the values work. It feels like, in some ways, this country is in a battle for its soul, broadly, and who deserves health care specifically. It's a battle for the moral values that are going to dictate what our communities look like now and what they look like in the future. So 2 things here. 1, your voice and your work and your advocacy are vital components of this battle. And two, if you are in this room, and if you are in this conference, and if you are doing this work, you are part of a larger community. How do we work to find joy in the struggle for justice together? That is our challenge here too. So I will leave you with that. I will turn it over to Dr. Rodriguez. Thank you for the work you do and for being part of this community.
That was fabulous. Thank you. And strong. So, good morning, everyone. I am Dr. Tanya Rodriguez, the Executive Director of Migrant Health Center in Puerto Rico. Today, I'm going to be talking about how our center was able to integrate a syringe exchange program. So before we start, I just want to, talk briefly of who we are. We are a health center located in the western region, northwestern region, and western region of Puerto Rico. We have 14 sites. You can see the colors is where we're located in Puerto Rico. These are some of the services that we render currently. Important to add that we serve over 34,000 patients and duplicate patients, and that all our clinics are certified by NCQA as patient-centered medical home and behavioral health integration. This is a little collage that I did of all of our different site clinics. This one below is our special price division, which I will be talking a little bit more. We've been around since 1971. So how was that process of integrating this project? Well, in year 2000, we were funded to operate a homeless clinic and to provide clinical case management and primary health and dental services. So once we got the funding, we started looking for an adequate building near where clients, where homeless clients congregate, gather, or lived. And we rented a small, space, and there we started providing the services. We couldn't provide the services inside our current clinic because our patients did not live near or did not congregate near. It had to be a place that it was a walking distance space to overcome all the, determinants of health and the transportation barriers and all the things that I'm surely you know by now. So, the part of providing the service was the easy part, but we started confronting different things that it did not let our clients to receive the services that they needed to. In terms of healthcare, you need to provide follow-up, you need to have a health plan, and the fact that our patients did not come in a regular basis, that was really difficult for us. So we started identifying what were those barriers, and one of the main barriers is that 98% of our homeless patients were people who injected drugs. And therefore, patients would not comply with their health appointments because they didn't have notion of time. So we also understood that their priority was not getting the care they needed. Their priority was finding money to buy drugs. And last but not least, when they did come in, there was somebody else being provided care, so they had to wait. And I wrote there 1 hour. The reality is that they couldn't wait 15 minutes. They could get sick or they get anxious, whatever, the reason. So for us, the big barrier was that homeless patients did not comply with their appointments due to that double, demographic that they had of injecting drug use. So as a team, we came up with a plan, and we said we need to start incorporating different services to make it appealing for our patients to come in. And so what we did, we started in the morning providing refreshments, coffee, making little things to see if they would, come at least to get breakfast. Years kept coming by, and we didn't see, we were still confronting the same problem, that patients were not accessing their appointments. So we said, we need to do something bigger. So by 2009, we were able to access funds, construction funds, and we were able to buy a building. And with those fundings, we remodeled the building, and we incorporated a bathroom area. We incorporated different things that kept including services that were appealing for our patients. We also started writing grants. We've received funding from CDC to provide prevention for HIV. There we were able to bring the more case managers, outreach workers. We were able to access funds to provide buprenorphine. That was very useful because that not only were providing a treatment, but we were able as well to incorporate mental health and substance abuse counseling services. And so we kept, the point is that we kept integrating things to see if patients came in. But you know what? We kept having the same problem. Patients were not consistent. And what changed it all? Well, in 2011, thanks to funds that were provided by AIDS United, we were able to incorporate needle exchange programs within our facility. That made a huge difference because patients began, and participants, because not all of them were our patients, participants. Participants started coming every day to exchange their syringes, because those who know, well, the culture and the subculture of our participants know that they rather inject with new needles. They don't want to reuse needles. So this is very appealing. And so it was a great benefit. Patients began to visit our facility, as I mentioned. We started being able to follow up because they came every day. The number of patient participants increased dramatically. We were attending like 400 or 500 patients, unduplicate patients. Boom, now we're in 1,200 unduplicate patients. We started in 2018, we were able to begin providing PrEP for people who inject drugs. We had the clinic, so it was easy peasy for us. It was great. And in 2012, we incorporated the dispensing syringe machines, which I love, and I would tell anyone that has this kind of program to incorporate these, because they overcome the time barrier. We work from 8 to 4, and on weekends we are not available. This is available 24/7. Each kit provides 3 syringes. The other option is a needle hygiene kit with a syringe, and another option is condoms. Everything is 50 cents. The money gathered is used to buy more supplies and to provide the maintenance. So it's a self-sustained intervention. I love it, I know. So how we divide our teams is that we have someone in the clinical, in the office, in the clinical space, or the office space is not a clinical area, because the building that we purchased has 4 different little houses, so each house has a different project. And the needle exchange is in one of those houses, but they're under a same facility, so everything is integrated. So we have a team that is always in the office space, and we have a team that daily goes out to shooting galleries, to high-risk venues, to provide syringe exchange, needle hygiene kits, condoms, Narcan, provide health education, among any other thing that we can provide to our clients. We do the monthly health fairs as well. But something very important in our street outreach is that we go to the same places every day. We do, on Monday, we do one town, and Tuesday we do one town, and our system works in accordance of our participants' behavior. We tailor our system to be available in the time that we know that they're gonna be congregating in that area. And we do that because we want to be, we cannot expect that they will know that on Friday, Friday 10 o'clock, they're gonna be there. No, they create a habit, and that overcomes the barrier of notion. So every morning, they know that, every Monday, they know that we're gonna be there. And I don't know if it's the sun, the light, but they know the time we're gonna be there. So it's awesome. So the part of being consistent with that is very important. And if we're not gonna be there, we tell our patients, our participants the day before, the outreach before, so they know, because we don't wanna upset them, we want them to trust us. These are other strategies that we've been using, telehealth. With a MedPod, we can go to the different places that our participants are at. This has the equipment, the entire equipment to do vitals and connect. If you see in that screen, you see the doctor and one of our team members who's a nurse. He's guided by the doctor, and she could provide care to our participants with the support of our nurse, our visiting nurse. This is a new strategy that we're going to be incorporating, I hope, before August. This is the office, a telehealth van where we can drive in front of wherever place we go, and the client will go into an office. We are recreating. Right now is in a place that they're doing like the remodeling of the inside to make it like an actual office. So I think this is going to be awesome. It's equipped with internet and all the things that you need to provide the service. So at this point, our target population is the community in general, but we kept writing and looking for funding to keep incorporating services. At this point, these are all of these logos are the different projects that we have within our special price division. We provide service to LGBT. We have for youth, for whatever. Everybody needs services. So these are most of the services that we have under one roof for our participants. We could have a homeless person who is a person who injects drugs, who is a trans person, who is a woman, who is a youth, who is whatever. And all of these populations have needs, and we are trying to get what we can in a same spot to provide better health care and continuum of care for our patients and participants. So this is a little bit about us. Our special price look right now. These are the little different houses that I was mentioning. We just purchased the last building. We're providing health care for the families of the people that we provide services in the special price division. actually an axis, an outside area. That's the one that you saw. So thank you. So now I'm presenting from Intercambios Puerto Rico, Luis Román.
I'm freezing. I come from the Caribbean, from the oldest colony in the world. We have 525 years of colony, 400 years with the Spaniards, and then 125 years with the U.S. as a colony. And why I'm telling you that? Because our political situation in the island creates inequality to healthcare, not only for homeless, not only for people who use drugs, but for all the island, okay? So yeah, it's important because we are treated like a third-class citizen. We have the same passport that you have, but not the same treatment to us. And that's equal when we are looking for funding to give health care to our people. Yeah, we are treating like a colony because we are a colony, okay? So keep this in mind when you are talking about this, when you're talking about health, okay? I don't know why I decided to speak in English, because Jose and I was talking that I supposed to speak in Spanish, but let's try. It's my first time presenting in English, so I'm gonna try it. We work in Intercambios Puerto Rico is a little organization, community-based organization in the east of the island, contrary of Migrant that is in the west. And I dream to have a clinic like Migrant. I think that, yeah, I think that Migrant, they are doing a great job, okay, so congrats. And I hope that we can do the same. So, as little as us, Intercambios Puerto Rico, we are a non-governmental organization founded in 2009, focused on reduce harm on people that use drugs, on people that do sex work, on people that are in homelessness situation, and every vulnerable population. So we don't just give service to only users or homeless people, but also for other vulnerability populations like public housing projects that we visit, and we integrate the healthcare and the harm reduction. No. We give health service in a harm reduction basis, okay? In a public health basis. So that's part of our team. We have the mobile unit, okay, where we integrate the healthcare service, psychologists, case managers, physician, nurse, peer education, and the little one is for the syringe exchange program. So we integrate both mobile units in giving the service in the community, because we realize that people that use drugs, people that are experiencing homelessness, like my colleague says before me, that they don't go to the clinics for a lot of reasons. And one of those reasons are stigma. Okay? One of those reasons is that because people who use drugs, they don't want to talk with their health provider because of the shame. Because historically, they're treated by stigma. Okay? And stigma is the most great barrier to go to any kind of service. So we're trying to eliminate that stigma. We try to give low threshold service to our participants, okay? And also, I want to mention, I used to work in a FQC, and I used to be the mental health director of an FQC. I know how that works, and I know that it's possible to do this in a FQC. We did it. Migrant right now is doing, okay? And I remember back in 2016, we began to create a mental health clinic based on harm reduction. okay? Based on community outreach, based on a mobile unit giving the service in the streets. Our office is the street. Our office is the community, not a clinical space. Maybe I'm a weird psychologist who doesn't like office spaces. I like the streets. I like the curve. Sit in a curve and make an interview in a curve. Okay? That's the way you have to work this. Not like a fancy psychologist with a fancy suit in a fancy office with air conditioning. No. We work in a streets with above 100 degrees. Bien sudado, very sweat. So yeah. So our mission is to promote social integration to marginalized groups, including drug users, homeless people, sex workers, working from a scientific perspective, but also with a human rights perspective. It's not the same when you said scientific basis, it's not the same human rights basis, okay? Because methadone is a scientific-based treatment, but Carla, when she was talking about the study about stigma on health providers, ¿cómo se dice muestra? Sample was physicians, nurse, psychologists, and social workers inside a methadone clinic. That was the sample. And could you imagine? You have the interdisciplinary team giving you service in a stigma basis. So, yeah, you have to put together science-based and human rights. That's important, okay? So, we give, through our harm reduction, we have programs that create activities for service, education, advocacy, and research, okay? Because it's important, the research. Yeah, it's important. A research that respects the human rights, a research that respects the sensibility of the people, but it is important, okay? And we need to converge community and research-based and human rights-based, because if we want to create public policy, if we want to create change, we need measures. Yeah, we need methodology, but sensible methodology, culturally sensible, and human rights sensible. So our mission is, we invade Puerto Rico where marginalized population have access to all opportunities for individuals and collective, okay? Develop that make it possible of them to have a dignified life and contribute to the society. We need to get access to service to our people that use drugs, to our people that are in homeless experience, people that are sex workers. They need access. But also all people in Puerto Rico doesn't have access to services, so yeah, that's a problem in any kind of population in Puerto Rico. Okay, so our geographic location is in the east of the island. We attend like 11, 12-ish municipality. 90% of people receiving service are men between ages of 24 to 45, and 100% they consider them Hispanic or Latino. That's a federal definition. I'm not a Latino, I'm a Caribeño. That's different. Also, it's different, okay? I speak Spanish, yeah, but I'm a Caribeño. I'm not a Latino. And because our condition, our political condition as a colony, Latin Americans reject us because they say we are part of the United States. But the United States treat us as a third-class citizen. So we are in the middle of something. Yeah, in the middle of the Caribbean. Okay? In the middle of the Caribbean. 50% of people live on the streets, and 100% live in extreme poverty. Okay? Right here, right now in Puerto Rico, we have like 30,000 each people that inject drugs. But we only give service, for example, in intercambios, only 900. Okay? So yeah, we don't have enough service. We don't have enough treatment in the island. We don't have enough. We only have to attend 8% of people who need treatment in the island. And half of that treatment spaces are not based on scientific and are not based on human rights. For example, therapeutic communities. Okay? They violate a lot of the human rights of our participants. So yeah, we don't have treatment. And I also asked two federal qualified community health centers in the island, sorry, where is the money? Because the federal government give you a lot of money to give buprenorphine, to give treatment, and I want to know where is the fucking money? Where is? Where is? Where is? So, yeah, we have a problem and we have the solution in our hands, and we don't have to wait for the government to create the movement, to create changes, because we have the capacity to do it. We have the capacity to do it, and right now we have the money. And I want them, show me the money. Where are the money to give services? So, population needs transportation, support, mental health, housing. Housing, fuck housing. I used to be part of the board of directors of a COC. You know what is a COC, continuum of care? You know how it creates this formula to give you the money to give service, to give housing. And yeah, everybody puts in the proposal, yeah, we're gonna give housing first program. Oh yeah, beautiful in the grant. Yeah, very beautiful. But not in the practice. Because when you want to enter in a housing first program, they wanna test you, a toxicology test. You have to be in treatment. You have to be stable. That's not housing first, but they only use it for the paper and for gathering the money, but not to give the services. And that's a fucking great problem. For example, you have to come to ambulatory services in a emergency shelter for 1 week, so I can see if I can give you a bed in an emergency shelter. That's crazy. Sounds crazy, yeah? But that's the way that we are right now doing the things in the island. So that's a problem too. Housing, okay? This is the map and the areas that we give services around all the east of the island. And this is part of our programs, El Gancho. El Gancho is a street slang in Spanish to say syringe. El Gancho, a hook. Okay, so in the street, participants in Puerto Rico calls the syringing el gancho. It's one of the words that we use. We use the rifle, el gancho, you know. So we are a project that works from the scientific perspective of harm reduction throughout prevention and counseling service for people who use drugs in 21 communities in the northeast of the island. We exchange more than 360,000 syringes annually to reduce the spread of HIV and hepatitis C. Syringe exchange, peer workers, safe sex, overdose prevention. That's part of the project. Right now, right here is Frederick. He is the coordinator of the syringe exchange program and navigation program in Intercambios Puerto Rico. They do a great job because it's not only give you a syringing, it's also create a conversation with your participant, because you don't only ask, okay, give me your signals, okay, your year of born, okay, are you using, how much long you're using, okay, how much times, okay, how many syringes you need, okay, take it. That's it. No, that's not harm reduction, that's not a syringe exchange program. And I learned from Gerardo, who is up here, and he creates the Gerardo syringe exchange model. And he creates a communication, a conversation with your participant, so you can move the participant, because I want to give you more services. I want to support you finding a housing, finding treatment, because a lot of people doesn't want to continue in that in that way, in that conditions, with wound, ulcers, a lot of ulcers. I don't know what happened right here in the United States. Why are they trying to use silencing, please? Oh my God. Okay, but we used to have that problem 20 years ago back in the island. So right now, we passed that moment because our participants and our inmates, prison inmates, they organize and they obligate the dealers to stop cutting the heroin with silencing. La Ñeta is an organization in the prison, so they organize to stop silencing back in the days, like 10 years ago. So, yeah, that's part of our job. So, we have Red Acceso, is Access Web. So, we navigate people who are in risk to having HIV. So we make easy for them to know their HIV status throughout tests, okay? Providing guidance, testing, and referral services about the virus. In addition, preventive navigation services are offered to young people, the LGBT community, and immigrants, okay? And also everybody, right now we have another program for youth, okay, to prevent HIV spread, okay, in schools and in other community-based programs. Sin techo, without a roof, yeah, that's another of our programs right now. Right here is Andrea, she is part of that team. We work to develop the necessary community infrastructure to be able to serve people with substance use and or mental health problems, coordination for placement in housing, okay? If you want to place people in housing, you have to go where the people are right now, sleeping in the streets, not waiting in an office that people go to ask for a housing. Please, you have to go. You have to go to the street. You have to go to the community, okay? So, we have a peer specialized case management, mental health counseling, and substance use disorder counseling. And my program. La Móvil, we have the RB, okay? So we give health service. This project has a nurse and a doctor to attend the physical and biological areas of the participant, integrating with mental health, psychologists, we are 2 psychologists, very weird psychologist that doesn't like offices. Sadly, we lost last year our peer worker because he dies from overdose. So yeah, Luis was a great teammate. But que viva Luis, que viva Luis. And also we have case manager with coordinate different service of social charter, accompanying referral, link to service treatment, and other necessary for help in the process. Right here is Brian Alvarado. He is our case manager in La Móvil. So, and we used to have this public policy program. The former coordinator of public policy was Carla. You already hear Carla talking about the stigma guidance. So yeah, she continued to do it, yeah. In another organization, but she continues and we collaborate together and we live together, so. So the purpose of that program is move public policy against war on drug. War on drug are killing our people, okay? Is not functional. Drug on war. What happened with this country that everything that you want is a war? War on drugs, war on poverty, war on AIDS, everything is a war. I don't know, maybe we have to change words, yeah, you know. So yeah, that's the part of our work is public advocacy and public policy changes. For example, we collaborate with the creation of the first law in Puerto Rico that allows community to have naloxone. I don't need a prescription. I don't need to be a physician. So everybody can have naloxone. So yeah, we collaborate in that kind of project. So that was last year. That was the first time that we have a law, okay, protecting people and protecting the naloxone from the police and from the authorities. So yeah. So we dream to have an FQC, okay, to create an FQC based on harm reduction like migraine, but it is possible to do this kind of job in FQC. That kind of job, we used to do it in an FQC. We create that kind of program in a FQC, and you have the money to create that kind of programs in FQCs. And you know that HRSA obligates you to create money, ¿verdad? To autosustentability, yeah? So you can use that money to buy syringes because are no federal money. You know that? Okay. So, yeah, you have the infrastructure to create and to change how these work. Thank you.
Hi, everyone. Oh, wow, this is such a beautiful sight. I'm so excited and honored to be here with everyone. Wow, that was a tough act to follow. I think that we are maybe on the precipice of lunch, so I'm gonna try not to take too much time because I want Catherine to have plenty of time, but I also, I wanna get a little bit into the weeds about the day-to-day of what it looks like to have an SSP at an FQHC. So I'm Molly. I am a nurse and our harm reduction program manager at the Baltimore Healthcare for the Homeless. We have we have several locations. The Fallsway, sorry. The Fallsway clinic is the main clinic, the largest clinic. But we also have a lot of offshoots. We have a mobile clinic. We have a convalescent care program at the Code Blue shelter. We also have a county clinic, a West Baltimore clinic. And I don't think I'm forgetting anything. We have, over the years, we've seen a huge increase, I think like many people in this room, in demand for supplies for people who are using drugs. And we found ourselves for a long time doing referrals out, which is great. I just want to take this moment to, and I'll say this again, but Baltimore Harm Reduction Coalition, none of this would be even close to possible without them. True, Reggie, Will, I bow down to you guys. I've known them since 2015 when I was a little baby nurse, and they've been